Hello friends, this is Dr. Rajesh Mishra and welcoming you in Health Super Specialist. As promised in the last video that we'll discuss the treatment part of community acquired pneumonia. We have already discussed the causative agents, the differentials, the CAP mimics and the symptomatology, the diagnostic part. Now coming to the treatment part. Community acquired pneumonia. How do we treat it? Or antibiotics? Of course, antibiotics, definitely antibiotics. Which antibiotics? That's the big question. I think we should categorize the patients of community acquired pneumonia. How do we categorize? First, any patient coming to OPD setting, okay, without any comorbidities. Patient without any comorbidities, no diabetes, no hypertension, no immunosuppression, no risk of methicillin resistant Staph aureus or no risk for Pseudomonas aeruginosa. Fine. What do we do? We give if the patient is healthy, hearty. According to the guidelines given by the American Thoracic Society and the Infectious Disease Society of America, the guideline states we should use a single monotherapy with maybe isolated amoxicillin or maybe doxycycline or maybe azithromycin, macrolides. So monotherapy. Patients who are at risk factor for what we discussed, a diabetic, a hypertensive, age more than 65, smoker, alcoholic, and all those risk factors are there. And if the patient is at risk for Pseudomonas or MRSA, then we have to think that what to give in an OPD setting and what to give in an IPD setting. So healthy patient at risk, definitely some comorbidities coming to OPD. We have to choose between a cephalosporin or some penicillin along with a macrolide. So the penicillin may be like amoxicillin clavulanic acid, 625 milligram, TDS, oral tablets. The cephalosporins, it may be cefpodoxime proxetil along with clavulanic acid. If not, cefpodoxime is also equally good, along with some macrolides or fluoroquinolones. So between macrolides and fluoroquinolones, we can make the choice, we can make the interchange, some cephalosporins or some penicillin plus a macrolide or a fluoroquinolone. We have to give 2 antibiotics if the patient is at risk coming to an OPD. Now, coming to patients who are community acquired pneumonia, who are severe community acquired pneumonia. As we discussed, the severe community acquired pneumonia, a patient who is in need of any assistance for breathing, a patient whose BP is less, either one of the two, like requirement of mechanical ventilation or septic shock along with respiratory rate of more than 30, tachycardia, multilobar opacities, PF less than 240, confusion, hypotension, hypothermia, etc. So what do we do in such cases? In such cases, we have to see whether the patient is at risk for pseudomonal infection. What are the risk factors for pseudomonal infection? Age more than 65. Patient admitted for more than 48 hours in hospital in the last 90 days. Intake of antibiotics in less than 90 days. That means any patient who has taken antibiotic in the last 3 months. Those patients will be at risk for pseudomonal infection. Patient on CKD, on maintenance hemodialysis, patients on immunosuppressants, any malignancy. So these patients are at risk for pseudomonal infection. Now, for inpatient treatment, we have to decide whether the patient is at risk for pseudomonal infection. We have to take in consideration these factors that I just told you. Suppose the patient is not at risk for pseudomonal infection. Then what do? We use any cephalosporins with a non-pseudomonal coverage. Like as we can use ceftriaxone, we can use cefoxitin, we can use cefotaxime, along with one macrolide, maybe azithromycin 500 OD or a Claribid 500 BD. You can switch between the macrolides or fluoroquinolones. You can use the levofloxacin. Data suggests that even ciprofloxacin has got better pseudomonal coverage than levofloxacin, whatever studies we go through. So this will be the choice of antibiotics if the patient is not at risk of pseudomonal infection. Supposedly the patient is at risk of pseudomonal infection. But the list that I just mentioned, that the list which was suggestive of the patient is at risk for pseudomonal infection. Anti-pseudomonal beta-lactams. The beta-lactams will remain the same. Previously we used like ceftriaxone